Good morning. First of all, I would like to thank the organizing committee for this invitation and for the opportunity to be here with you today to talk about labor induction in twins. Twin pregnancies are associated with an increased risk of obstetric complications such as hypertensive disorders, gestational diabetes, fetal growth restriction, growth discordance, preterm delivery, and long-term disability. According to a report published in April 2012, twins compared with singles had twice the risk of preeclampsia, gestational diabetes, and preterm labor, and 50% of the twins deliver before 37 weeks, which tell us that the other 50% were undelivered at 37 weeks. The best outcome for twin pregnancy is the delivery of two healthy babies. A paper published in 1998, analysis of US cohorts showed that the perinatal mortality rates were lowest at 40 weeks of gestation for singletons and 38 weeks for twins. Another paper published in 2001 show us that term twin pairs face more than 5 times the risk of perinatal mortality, perinatal loss, fetal or neonatal deaths of one or both twins seen among singletons. In the same paper, they sought to determine the gestational age of delivery for twins that was associated with the lowest perinatal mortality rate, the lowest incidence of respiratory distress syndrome, and the lowest rates of long hospital stays. And they found that the optimal gestational age for twin delivery was 37 to 38 weeks of gestations, and the conclusion was that induction of labor at 37 to 38 weeks of gestation should be routinely considered in twin pregnancies. Another paper, Another paper published in 2004 showed that it was a retrospective cohort study of more than 1 million twin live births in USA, showed that the rates of labor induction had and labor and cesarean birth, it's impossible to have the point. Okay, I have the point. Cesarean births among twin live births increased by 138%, the labor induction, and 15% the cesarean rate between 1989 and 1999. Doesn't work. It doesn't work. Okay. During the same period, there was a 43% decline in the stillbirth rate, which was larger at later gestational age, where the largest absolute increase in labor induction rates were observed. And Annans in 2004 emphasized that the decline in the stillbirths was closely associated with increasing rates of medically indicated preterm birth. Since 1986 to our days, there have been multiple papers on the subject of induction of labor in twins. We have published 2 of them, the first one in 1999 and the last one in 2006. How can we induce twins? We can induce twins using a device like a Foley's catheter or a balloon, or we can we induce in the mechanic point of way, and we can induce using a pharmacological drug. The most used is oxytocin. We can also use dinoprostone, intracervical or intervaginal dinoprostone, and misoprostol, in which we have plenty of experience. Usually, we use 100 micrograms orally or 50 micrograms vaginal, which can be repeated 6 hours later if the labor did not start and could be followed or not by dilute oxytocin augmentation. But it's important to notice that not all twin pregnancies are candidates for labor induction. And our selection criteria is always biamniotic gestations, always with the first twin in a vertex presentation, no history of previous uterine surgery, no contraindication to vaginal delivery such placenta previa, and informed consent. Our protocol in protocol in 2012 is: if we have a Bischoff score less than 3, we perform an elective cesarean section. It's the easy way to deliver the twins. If the Bischoff score is between 3 and 10, we do the labor induction using misoprostol. And if we have a very great cervix with a Bischoff score more than 10, we use oxytocin. We start 100 micrograms of oral misoprostol, and 3 or 6 hours later we start a perfusion with oxytocin if we need to start. And if labor is progressing normally and we have a good CTG safe, we do the vaginal delivery. If we have an arrest of labor or signs of fetal distress, we perform a cesarean section. Let's speak now about our experience. From our database, we had selected 1,040 twins delivered with 36 or more weeks, with both twins alive. From these, 779 were dichorionic twins and 261 were monochorionic twins. We had 196 labor inductions in the dichorionic pairs and 77 in the monochorionic pairs. We induced twins because of postpartum pregnancy or maternal or fetal problems. 92% of the case, the labor induction was done with 100 micrograms of oral misoprostol. And about twin birth presentation in 25% of the dichorionic pairs, and in almost 30% of the monochorionic pairs, the second twin was not in a vertex presentation. We are going now to compare our dichorionic twins with our monochorionic pairs, and we do not find statistically significant difference with regards to age, parity, pre-gravid BMI, history of premature contractions, diabetes, and discrepancy. We do find statistically significant difference with respect to spontaneous pregnancy with a higher rate. It's usual to have a higher rate in the monochorionic pairs, and hypertensive disorders with a higher rate in the dichorionic pairs. We do find statistically significant difference on respect of gestational age of delivery, with a higher gestational age, average of gestational age of delivery in the dichorionic pairs. Cesarean section, with a higher rate of cesarean section in the monochorionic pairs, 18%, and almost 8% in the dichorionic pairs. This is a fail of the labor induction. The duration of active phase of labor and the average mean inter-twin interval with monochorionic twins with a lower duration of active phase of labor and lower duration of mean inter-twin interval. We do not find statistically significant difference on respect of vaginal delivery, successful labor induction, or combined delivery, vaginal cesarean, with amazingly the monochorionic twins with a lower rate. About neonatal problems, we find statistically significant difference on the respect of the birth weight of the first twin, which was heavier in the dichorionic pairs, and the length of stay of the second twin, which was lower in the monochorionic pairs. You can see that Apgar score less than 7, we have 4 cases in the dichorionic twins and only 1 case in the monochorionic twins, in the second twin. We have fetal mortality, 2 cases, a trisomic fetus in the dichorionic pairs and 1 major cardiac malformation incompatible with life. And when we look to the neonatal records, we only find a mild fetal asphyxia, 5 cases in the dichorionic pairs and no cases in the monochorionic pairs, 1 case more than the Apgar score less than 7. About maternal problems, as you can easily find, we don't have really maternal problems. No case of maternal mortality, no cases of rupture of twin, and the maternal man length of stay in the hospital very shorter. So in conclusion, when we look to our labor induction in dichorionic and monochorionic twins, in 90% of the cases we had a vaginal delivery of the first twin, and in 29 cases we needed to perform a cesarean section, more cases in the monochorionics than in the dichorionic pairs. We try to find predictive factors for a successful labor induction. Several papers speak about higher parity and higher Bishop score to have to be a positive factor, and higher BMI, excessive weight gain during pregnancy, height with firstborn twin as negative predictive factors. And looking at our database, we have here the successful vaginal delivery, and here the cesarean section, the unsuccessful vaginal delivery, and only parity. We only find statistically significant difference between both groups on respect of parity, with the group of unsuccessful vaginal delivery with a higher rate of nulliparous than the successful vaginal delivery. We do not find statistically significant difference on respect of vertex presentation, history of premature contraction, because we don't have the records of Bishop score, maternal the mean final maternal weight, pre-pregnancy BMI, obesity or birth weight of the first twin. When we speak in singletons about labor induction, we know that labor induction is significantly associated with cesarean section. We are going now to look to our database, and we have selected the spontaneous labor, and we have chosen the woman with conditions to have a vaginal delivery, so the vertex and vertex bridge twins, and the mothers with no previous uterine surgery. And if you look, we have a rate in labor of cesarean section in the dichorionic pairs of 28%, and in the monochorionic pairs the 32%. Much higher rate than in the labor, in the group of labor induction. But before inducing twins, we should consider the patient desires or fears. The obstetrician experience in vacuum, forceps, sternal version, breech delivery or breech extraction. the neonatologist capacity, and it's important to have informed consent. Induction of labor should be offered to patients in whom near-term vaginal delivery is unequivocally permitted and to those who prefer the vaginal to the abdominal route. Induction of labor in twins needs close observation throughout the entire process as well as during labor and delivery. The delivery of twins is a high-risk event regardless of how it progresses. It's why we need the informed consent, and the medical team should include 2 physicians, at least 1 with experience in the obstetrics maneuvers. A sonographic assistant, it's very important in the delivery of the second twin. Anesthesiologist, 2 neonatologists, 1 for each twin, and a dedicated nursing staff. The fear of induction of labor-induced fetal distress should not negate its use. And to the question, should we induce twins? Our answer is yes, we should. Thank you.